Prepare to brace yourselves.
Hello everybody, welcome back to yet another video where we're still talking all about teeth, all about dentistry, and today specifically all about bracing yourself. Today I have a very special guest who I am so excited to introduce and have on this platform. We have a specialist orthodontist, owner of OrthoSmile, Dr. Nhembe. Welcome to the platform, Dr. Nhembe.
Thank you, Tracy.
So, Dr. Nhembe, before we get into it, I'm sure all the viewers are itching to know who this gorgeous specialist is with us today. So please do just introduce yourself. Who is Dr. Nhembe, maybe your journey to orthodontics, and who you are inside and outside of OrthoSmile.
Okay. Well, flattery will get you everywhere. Right, I am Dr. Nhembe, or Dr. Farai. I'm a specialist orthodontist. I've been an orthodontist for coming up 13 years now, I think, maybe even 14. Time is flying. So just for people who don't know what an orthodontist is, the word orthodontist has roots in the Latin language. So ortho meaning straight, dente meaning teeth. You put them together. We are pretty much the straight teeth doctors. Okay, people know us as the braces guys. Braces are everywhere these days. You see them on TV. You see them on your neighbor. Soon we'll be seeing them on the dogs and cats, I'm sure, but everyone knows about braces, so we are the braces specialists. I started my training to be a dentist first, so I graduated as a dentist in 2006 and then did specialist training. Before becoming an orthodontist, I did a course in oral surgery and also worked in a hospital as a maxillofacial surgery senior house officer. And following that, I also did a year in pediatric dentistry and working with patients with special needs. That took me, I probably think about 3 to 4 years, and then went into specialist training for 3 years. And since then, I've just loved being in the profession. I hated, absolutely, I need to be very frank, hated dentists as a child. I was in and out of dental surgeries, and I actually had braces myself when I was 10 years old. And I think probably having gone through that experience as a child just made me interested in it. And when I went, I took a gap year after A-levels. And during that gap year, I worked as a dental nurse, and that just rekindled the passion for dentistry. And as I went through, I then settled on orthodontics, and I've been in this field ever since.
Oh, wow. That was a very interesting introduction from Dr. Nhembe. As you see, we have a very experienced specialist orthodontist here with us today. Getting right into our first question that we have for Dr. Nhembe today. Today our topic is brace yourself, because we're talking all about braces, all about orthodontic work. Now Dr. Nhembe, there's this misconception, I'm not sure if you're aware of it, in the general public, where people think that ortho and braces is all about aesthetics, it's just a fashion statement. But could you tell us that ortho is actually a life-transforming treatment? Outside of aesthetics, outside of looks, it transforms your life in terms of form and function. So could you just introduce us to what is orthodontics and why is it such an important branch in dentistry?
Tracy, you're absolutely right. There is this big misconception about orthodontics. It's a battle for us, a constant battle as specialists to try to explain to people, and quite often in the insurance companies as well, that it's not just about the aesthetics. The aesthetics are part of it. Obviously, if you go through orthodontic treatment, you're going to look better. Well, you should. If you don't, then you need to change your orthodontist, okay? But there is a lot more to it. And as I mentioned, orthodontics means straight teeth, but it's not just about the teeth, because the teeth don't float in the middle of air or, you know, in the middle of the face. We've got other structures attached to them. So we've got the bone, we've got the ligaments, we've got the jaw bones themselves as well. And that's all part of the specialty. I often say, you know, we're not just looking at braces and looking at the teeth. We as orthodontists are responsible for the growth and development of the child as well. So we are looking at not just where are the teeth situated in terms of next to each other or within the bone. We are also looking at how is this child growing? What are we predicting the growth going to be? Can we modify it? Can we, you know, get them into a better position of function? So you see, I've mentioned the word function. It's not just about how do the teeth look, how are they working? Everyone has teeth apart from little babies. I have a little baby that is obviously not eating at the moment because they don't have teeth. So obviously the position of the teeth is important for function. We know that if your teeth, for example, are protruding very far forward, you're going to struggle a little bit with eating things like pizza, biting into things. They're really, really important to be in the correct position. But we know that if your jaws are not in the correct position, that's going to affect that as well. So we are looking at what do the teeth look like. We're also looking at the growth and development of the child. Then we look at the function as well. We sometimes, as orthodontists, we have a little bit of an overlap with the oral surgeons. So for example, if you have a patient who has a cleft lip and palate, that people might only, you know that from the big adverts on TV and the life-transforming surgery, as you said. But what happens after that life-transforming surgery? They're going to look better, they're going to have better function in terms of the lip being together or the jawbone being together. But what about the position of those teeth and getting that bite into a better position? That's when we come in as orthodontists. So sometimes we have a little bit of an interplay with the other disciplines, ENT, for example, as well, the ear, nose and throat surgeons. If we have someone who has adenoids, you would know that usually if the person is breathing through their mouth a lot or snoring at night, we can work with the ENT surgeons so that that surgery is done. And usually there are repercussions of having, for example, if a patient is breathing through their mouth, they might end up with an anterior open bite where the teeth don't come together. So the surgeons would go in first and deal with the adenoids, and then that patient would still need to come to us. So there's that interplay, that it depends who sees the patient first. Sometimes we will see the patient first and refer outwards, sometimes they are referred into us. So I agree, these days it does seem to be a fashion statement. I know that there was a time in Korea that there was an issue of patients buying braces that were stuck on with super glue. So just not actually functional braces, but sticking them on just to have an appearance. And you know, there's this misconception that you are wealthy if you have braces, or you're from a certain social class or that sort of thing. But the message that I would want to get out is, yes, it's great that people enjoy the way that the braces look, and you know, the children can have lots of fun with having colors on the teeth and things like that. But ultimately, that this is something that we're doing for the health of the individual.
Wow. And you've heard it for yourself, orthodontics or braces isn't just for looks, for aesthetics, or to seem a certain way in terms of your profile in life, but it is to transform you, form and function. Alright, Dr. Nhembe, now that we've talked about this branch of dentistry, what it is, why it's so important, could you kindly just let us know who needs it? Who needs orthodontic treatment? Who needs to brace themselves? And at what age do you recommend this to be done? And what causes these orthodontic problems, Dr. Nhembe?
Well, the better question is actually who doesn't need orthodontics, okay? Studies have shown that 60% of the population actually have a malocclusion, and malocclusion simply means a bad bite. So that's 60%. But do we see 60% of the population? I wish we did. You know, I'd be cruising around in a Rolls Royce by now. But actually, not all patients. So of that 60%, we know 60% of the population have this bad bite, but not everyone needs to have that corrected. Some of the bad bites are minor. You might have a little tooth that's a little bit rotated, and you know, I'm one of the orthodontists that sometimes agrees that yes, it can add a little bit of character to that person. But where we want to intervene is when that malocclusion is causing other problems. So you might have a patient who's got crooked teeth that are now causing gum problems, for example, or we're starting to get holes in the teeth because they aren't accessible. So those are the type of patients that we want to see. In terms of when the best time to see an orthodontist is, we recommend and we follow the guidelines from the American Orthodontic Association and the British Orthodontic Society mainly. And that recommendation is to see a child for their first orthodontic checkup at age 8. And the reason for that is, at age 8, we've got this mix, we call it a mixed dentition. And it's where we still have some baby teeth, we still have some of the adults' teeth coming in. But in terms of growth, we haven't gone through the major growth spurt. So we can come in at that stage and see, is there anything that we need to do at this stage to make things a little bit easier later on? And that's something that we would call interceptive treatment. So it's little things like, for example, if one of the children is sucking their thumb and, you know, mom and dad or teachers and everyone have tried everything from putting a plaster on that thumb to a little bit of chili sauce. You know, people have tried all sorts of things to try and stop the habits. Sometimes they'll come to us and say, look, I've tried everything, is there anything else we can do? And the answer, of course, is yes, we can put in habit breakers to try and get rid of that habit earlier, which will then avoid that becoming a more serious problem later on. That type of patient, we can pick that up at age 8. There are other things in terms of the growth that we can modify early on to once again avoid a problem later on. There are also some types of growth disturbance that can only be corrected between age 9 and 11. So that's why we want to see that child at 8 years, because if we're going to correct it, we want to get in there early. But I would probably say the majority of treatment is done in adolescence, so when the patients are in their growth spurt. So we're aiming for between age 12 and 14. It's a great time to be having treatment. They don't have a lot of, you know, like a major workload at school. So that's the ideal age that we would want to go in. But saying that, we have adult patients more and more these days. I remember Tom Cruise, who maybe some of the viewers don't remember, but he was actually one of the actors that made orthodontics, you know, out there in the public eye. People started seeing him with braces, and then it became a bit more common for adults to say, okay, well, Tom Cruise is in his, I think at the time he was in his 40s, and they said, well, he's in his 40s, he's an adult, and you know, it became a little bit more normal for adults to have treatment. But saying that, some adults will come in because they didn't have the opportunity to have braces when they were younger, or it wasn't commonplace, it wasn't something that you saw, you know, every day. But a lot of adults get referred to us now from other dentists or other specialists because we can work in conjunction with them. Implants are another thing that are becoming increasingly popular, so that would be a replacement tooth, and sometimes the dentist won't have enough space for that implant. So they could write into us to ask us to open up some space or close some space or, you know, modify or derotate some teeth just to make their treatment a little bit easier. So we find now that there's no ideal age to come and see the orthodontist. Everyone is welcome. The older patients we have are in their 70s, and you know, sometimes you just want to treat yourself and give yourself that smile that you've always wanted. So, what causes these problems? Often you've heard of nature versus nurture, okay? And that pretty much means genetics versus environment. So there are genetic factors and environmental factors. Most of these teeth problems, like in terms of the straightness of the teeth or the position of the jaws, the size of the jaws, the size of the teeth, and the number of the teeth, these are all inherited factors. So you get them from your parents, okay? And sometimes it's just that you inherit the size of jaw from one parent, the size of the teeth, and it just doesn't match. You can also inherit other features like your lips, your tongue. These are all inherited features. So in some cases, if you have the misfortune of inheriting something that's going to then cause a dental problem, that's when you're going to need orthodontic treatment. And then we look at, conversely, environmental factors. You can have a patient who has perfect teeth, but then they've got this habit of sucking their thumb. That's going to be an environmental factor, or something that's brought in that's going to then move those teeth into a different position. And you can have other factors in the environment, for example, the diet, that might modify and then cause a malocclusion.
So Dr. Nhembe mentioned to us the different orthodontic problems that could arise due to nature what are the different appliances that are there to fix these orthodontic problems?
Okay, so there are a number of appliances, and I'd probably say the easiest way to start is to split them into removable appliances and fixed appliances. So we have a variety here. This is quite a common appliance that's used, and it's called an upper removable appliance. You can get a lower removable as well. It's pretty much a mixture of wires and acrylic. And with this, we can solve little problems, like for example, if you've got a narrow mouth, you might want to get a little bit of expansion. So we can use this type of appliance that will clip into the mouth. This wire will be at the front, which is a guiding wire. It will guide the front teeth and also help to keep the brace in the mouth. On that, we can also add things like screws. And this one is an example. It's got a midline screw, and that's something that we teach the parents and the child how to turn that screw once a week, or depending on the prescription, it might be a bit more often than that. And that's going to separate the two halves of that plate, and whilst doing that, it'll be pushing the teeth and the jawbone apart a little bit so that we get a bit of space. So this is quite a handy little appliance. And as you can see, this one is bright green. They're fun. You can make them lots of fun. You can have orange, pink, whatever. And we do that mainly so that the child doesn't lose it. Because children are notorious once they have this brace, it is removable. And as I always say, the problem with a removable brace is it can be removed. So they take it out. Usually it's in place most of the day, but it's taken out when eating, when playing contact sport, or when brushing the teeth. And in those cases, we always give the patient a little case to keep it in. But this is quite common for correcting little problems. So if, for example, you want that little bit of expansion, or you want to just push a single tooth back into position, or in cases where you've got front teeth that are flared, so spaced, you can use this guiding wire. By closing up these little ends, you can then push those teeth in. So I quite like this appliance. It's handy, but it's not very complex. It doesn't get complex movements. You're getting sort of one-dimensional movement with this. And another type of removable, it's a device, it's not an appliance per se, but something like a gum guard. And these are really useful because sometimes we aren't aiming to treat, but also prevent other problems. So if we have a patient who's got teeth that are further forward than they should be in the top, and we're not quite ready to start treatment because we're waiting for some more teeth to come through, we would then recommend that they wear a gum guard, which would then protect the teeth whilst they're playing sport. And so that would be an example of a removable orthodontic appliance, but it's not actually putting any force on the teeth. And then we move into something that is becoming increasingly popular, and this is something called an aligner, and that is technically a removable appliance because we're getting a little bit more complex movement out of this, and it's a certain type of treatment that is similar to using fixed appliances in that you get three-dimensional movement, but that is also a removable device. And then as we go through treatment, we mentioned that for children and adults who have habits like thumb sucking, so commonly in the younger children, we can put in a device that's going to help them stop sucking that thumb. So this, for example, is a rake design, and it is a habit breaker appliance. So for a child who's got that habit, for example, if it's a thumb sucking habit, this will create a little bit of contact on the thumb. Usually, I used to be a thumb sucker, and one thing that I always say to the patients is it's the juicy feeling. It's this contact that you get with the palate. That's what makes it fun. And that's what makes it a habit. Obviously, thumb sucking is not something that you just start doing for the fun of things. We have found that, children in utero are sucking their thumb, and it's something that people do to soothe themselves. Okay, it's like a little mechanism to help children fall asleep, or when they're feeling a little bit panicky or anxious. And in those cases, it's really hard to stop that habit. And so having something like this in the way of where the thumb normally makes contact with the palate, that's something that's going to help them to stop that habit and to break the habit. So it can be cemented, and by cemented I mean glued in place onto the back teeth, so these are the back molars, and it's glued in place so that it's quite rigid and firm. And then once the habit is broken, we tend to leave it in for another 3 months just to make sure that the habit doesn't come back. And then once the habit is completely broken, you can then simply just remove it again. The type of braces that most people know about are fixed braces, okay? These are your railway tracks where people start calling you brace face and all sorts of things. This is what most people know. And these consist of little metal squares, which are called brackets, and these are individually glued onto the teeth. And it also then interacts with the wire that goes through those brackets, and at the back little tubes or little rings are used to hold the wire in place. And that is how the force is then transmitted to the teeth, and that's how we start to move the teeth around. So this is your most common day-to-day fixed appliance.
Okay, so how regular are these appointments, Dr. Nhembe, when one is coming in for orthodontic treatment, and what goes into these checkups and appointments? Yeah.
Okay, on average we see a patient every 6 to 8 weeks. Okay, so when the patient comes in, they usually start off being seen by one of the assistants or the hygienist or therapist, and this is just to ensure that they're managing to look after their braces. We're checking the health of the teeth, the health of the gums as well, and then the orthodontist will come in and check the progress. So by that I mean, what did we prescribe or what are we trying to achieve? If we're trying to do an individual rotation or move a tooth in a certain direction or close some space, we're just checking to see how that is progressing and whether we need to move up to the next wire or to the next stage of treatment.
Okay. So moving right along the dental students are the main people who might be watching this, and they might be interested to know what really goes down in orthodontic appointment, what really goes down in one bracing themselves. So you kind of just let us know what happens during an ortho appointment, from examination to diagnosis and treatment planning.
Sure. An orthodontic appointment actually starts before the appointment. So the important thing is whoever is seeing the patient first, so if they're being referred in, or that initial phone call, because we want the patient to have as much information as possible so that they know what they're coming in for and what to expect. So what can they expect? Like any patient, the first thing is to check the medical history and the dental history. Because we're going to have this patient in the practice with us, we want to know what kind of stage or state of health they're in. And once we've checked the medical history, usually one of the orthodontic assistants will come and introduce themselves to the patient and then proceed with taking some x-rays. In orthodontics, we tend to use two main x-rays. The first one is the lateral cephalogram, which is a side profile x-ray. And we use that one because we want to assess where these teeth are lying in terms of in relation to the upper jaw and the lower jaw. So we can assess the skeleton from this x-ray. We can also see whether the patient is about to go through a growth spurt, and we use that using the cervical vertebra maturation. So we can actually assess, is this patient at the end of a growth spurt, at the beginning of a growth spurt, have they got any more growth left? With that x-ray, I can also use it to assess the position of the teeth, so the angulation of the teeth and also the angle of the lower teeth in relation to the upper teeth. We can also see the soft tissues on this x-ray. So we can see the adenoids. We can also assess the position of the lips and the chin and also the nose. Once we've taken that x-ray, we then take a full mouth x-ray, which is a pan-oral x-ray. And this one is really mainly for screening. We want to see generally what is the condition of the jaw. We're looking as well at the condylar appearance, so we're looking at the TMJ as well. So this is the temporomandibular joint. Once we've done a growth assessment as well with this, we can look at, are the wisdom teeth coming through? Are they in position at all? Are they starting to develop? So we can then assess, does the dental age of the patient match the skeletal age? And on this x-ray, we're also just looking to see, do we have adult teeth? Are we still dealing with baby teeth? When are the baby teeth going to be lost? That sort of thing. And we can also assess the sinuses on this x-ray, so it's a really useful one for just checking the general dental health of the patient. Once we've had our x-rays done, the patient will then proceed to the clinic, and it depends on the style of the orthodontist. At this stage, the orthodontist might come in and do a full examination. So this examination starts with the extraoral, so looking at the appearance of the patient. I tend to look at how is the patient even walking into the room, because we're looking at the growth of the patient, the size of the patient, and then we start focusing in a little bit on how does the face itself look. So we're looking at the position of the lips, we're looking at the nose, we are looking even at the eyes. You know, we're looking at this general outward appearance of the patient, and then we start to go into a little bit more detail coming into the mouth, and we do a general dental checkup, the same that you would have done by the dentist, just not in terms of the detail of, you know, which tooth needs a filling and that sort of thing. We are looking at which teeth have had fillings. Has the patient had a lot of dental treatment before, or do they need some dental treatment? Because a lot of people might want to rush in and have the braces, but it's really important that the teeth are healthy and the gums are healthy. So we're going to do a general check of the gums as well. We always do a check of the soft tissues, so looking at the tongue, the cheeks as well, because it would be really embarrassing if you came for an orthodontic appointment and we just focused on the braces and didn't pick up something serious like oral cancer or something else that's going on. So once we've done that general check, then we focus in on the bite itself. So we're looking at the position of the teeth. So usually we'll start with the incisor teeth, so these are the front teeth, and we're looking at where the lower teeth lie in relation to the upper teeth. Then we'll start to go around and look at the position of the canine teeth. What are the molar teeth doing as well? Are they, you know, a little bit too far forward? Are they too far backwards? That sort of thing. So we just get a little bit more in depth as we go through, and we start to look at things like the midlines of the teeth, which teeth are rotated, which teeth are in the incorrect position, and then we'll start to look a little bit more and focus on the bite itself and, you know, where the teeth are lying. And we always then finish the examination by coming back out again to check the temporomandibular joint again in function, because now we've had a little look at what the teeth are doing, what the bite is doing, and we put it all together. Once the intraoral examination is done, if we have a patient who is ready to start treatment and is going to proceed with it, we will first have a discussion with the patient. We usually move to the table and show them the x-rays and go through the treatment plan and what we would expect for treatment, how long we would anticipate it to take. At that stage, if the patient is, as we say, signing up or coming on board, then we would proceed with taking models, so molds of the teeth, which would give us something like this, which is a stone model of the teeth, or we can scan that digitally. And at that stage, we will then do the final stage of the examination, which is to take clinical photographs, which will all form part of the patient's record.
One thing people forget, Dr. Nhembe, especially with the husband, is having wires on the teeth and the possible potential pain they can be in when it comes to bracing yourself and using orthodontic treatment. But could you kind of just tell us a bit more on the painless potential of orthodontic treatment, or how to manage pain in cases of using, and also how to manage your diet? I know people are afraid, oh no, I can't have a burger, I can't have the food that I really like. Could you just tell us how someone can effectively, you know, plan their diet when it comes to bracing themselves?
Pain. I don't like the word pain. Okay, so in this practice, we do not use the word pain. We use the word tenderness. And we might say a little bit of discomfort. It might pinch a little. We don't use the word pain. Orthodontics can actually be pain. I wouldn't say painless, okay, because obviously pain is a concept that is different for everyone. So if I was to just do this, I might say, oh, it pinches a little bit. For someone else, they might scream and say, no, that's painful, okay? But what we're aiming for is a journey that has as little discomfort as possible. And it is actually possible. And the main thing is preparation. A lot of patients will come in and say, oh, I took some paracetamol before I came to my appointment. I don't think that's necessary because, you know, for that little bit of discomfort that most people have, it's because we put the brackets on the teeth, we put the wires in and engage them, and then the force levels are transmitted to the teeth. As that builds up, that's what the patient starts to experience as what they might term pain, okay? But that pain is actually important because it elicits a little bit of an inflammatory response in the body. So we actually want that discomfort to come because then the body is going to then react to that, and that's where it then sets off a whole process biologically that's going to cause movement of those teeth. So it's actually a good thing if you're feeling that little bit of discomfort. If you are completely painless, we have to start questioning, is anything happening? So it can be managed. We tell patients to take some paracetamol. There are, like I said, complex processes within the body that are occurring. So if someone takes ibuprofen, for example, it will block that pathway that we are using to move the teeth. So we actually prefer for people, if they have that little bit of discomfort, to use some paracetamol. But you don't have to run straight to medication. You can actually do simple things like having some ice water. That's going to relax the wires and make things a little bit more comfortable. Especially things like the diet. People might want to get braces and rush back into eating the things you've been eating every day. You do have to modify your diet in general. My motto is nothing hard and crunchy, nothing chewy and sticky. If you stick to that, you're going to be fine. And that's because we want the braces to remain intact on the teeth. So it's not a way of punishing patients or making them have a bit of weight loss. You know, it's actually just a way of maintaining the integrity of the brace. If you drop down to that softer diet in the initial days, because this period of discomfort is not the whole way through treatment. It's usually if we are closing spaces and we ramp up the forces, things like that. And it's that initial week to 2 weeks while the body gets used to having these appliances on the teeth. So during that phase, modify the diet, soft things, bananas, smoothies, yogurt, you know, that kind of thing is going to help you get through that initial discomfort. Then, if it's a little bit more or something that people can't bear or it's starting to disturb sleep, that's when you're going to need to bring in the paracetamol or something a little bit more heavy duty.
People are also worried about when it comes to extraction do you always extract the teeth before you
So there's a big debate in orthodontics, and it's called the extraction versus non-extraction approach. So this is something that's been going on since probably the onset, the birth of orthodontics. It's always been this wave of a non-extraction approach, and then suddenly we need to take teeth out. And where we are now is we treat for that patient, okay? Some patients need to have teeth taken out, some patients don't need to have teeth taken out. Patients will often say, oh, I have too many teeth, I need to have teeth taken out. And it's not so much a case of too many teeth, but I say too many teeth for the bone that's available. So if we've got a patient who's got a lot of crowding, so the teeth are, you know, definitely out of position, but the base of the teeth seems to be okay, then we're going to have to extract some teeth so that everything can fit into the mouth and be harmonious in terms of the bite. Some patients have a really, really narrow jaw. So if the jaw is narrow, but we know we need a little bit of space so that we can fit all the teeth in and get them straight, we can do that without taking teeth out. And that's using a technique of expanding. So we want to widen that smile. And as we widen the area that the teeth is sitting, we tend to then not need to extract any teeth because we're going to get little gaps forming as we get that width increase, and then we can get all the teeth in nicely. So it's not so much an approach, you know, there's also been talk of, oh, it's an American smile because it's broad, and it's a British smile when it's all narrow because they've extracted teeth. But where we are now, it's not so much about location or the type of brace that you're having. We treat to the face and we treat to the patient. So if we can avoid extractions, obviously that's going to be our aim. But sometimes we need to get some teeth to be in a better position, and we're going to have to extract either premolar teeth, so the smaller teeth further forward near the canines that need to be extracted, or in some cases the extractions have nothing to do with the crowding. It might be that we need wisdom teeth to be extracted because they're going to interfere with the positioning of the molars further back, or we need some baby teeth to be extracted so that we can bring in the adult teeth to the correct position. What we tend to look at with extractions as well is the facial form. We spoke about patients being worried about how they're going to look at the end of treatment. If we extract, we know that if we're not careful with our mechanics as orthodontists, so how we're moving the teeth, we can end up flattening the patient's profile, and that would give them a premature aged look. So it's something that we do in conjunction. We're looking at the facial form and we're looking at the position of the teeth, and then we make a decision of whether we need to extract or not.
An added fear that comes to bracing oneself is definitely the change that happens to one's face after orthodontic treatment. Could you just tell us a bit more on this change? Is it really expensive, and what are the benefits of this change that happens after orthodontic treatment?
Okay, so change can sometimes be a good thing. okay? We shouldn't always be afraid of change. In some cases, you actually want to have a change. The patient might come in and their lips are pushed forward and they're just not happy with their appearance. So you would actually want to effect a change in that case. A patient like that isn't going to be happy if they leave and the teeth are perfectly straight, but facially there's no difference. And then people say to them, are you sure you've had treatment? In some cases, we want to see this change positively. We want to avoid having a negative change, obviously. And that's why that planning, the treatment planning, is the most important thing. A lot of people think you come in for an orthodontic examination and the next thing, or on the same day, the braces are put in. But there's a little bit of a stage that we hardly ever speak about, which is the treatment planning, and that's where the orthodontist goes back to the drawing board. You go back and you're looking at the x-rays, you're looking at those clinical photos of the patient, and you're just trying to see, what don't I like? What doesn't the patient like? What kind of changes can we actually get? We want to improve the facial appearance. So if we have a patient who smiles, but the smile is just generally flat, I want to see, can I, lift the corners of the mouth just by the position of those teeth? And how can the soft tissue, so we're talking about the lips and the nose, how can that position influence the patient? So if we find, like I said, the patient has more of a dished in appearance, they're going to look older than their years. And by moving the teeth into a better position, you're going to give a little bit of plumpness, a little bit of free fillers, if you might. A lot of patients these days are looking for Botox and looking for fillers, and sometimes it's just the position of the teeth that's incorrect. And by going through that treatment, you're going to have a better appearance. So I would say, don't be afraid of, changing the appearance. That's why it's so crucial to talk to the person who's doing your treatment. Tell them what you don't like. It's not just the teeth sometimes. Tell them your fears. I'm worried that, I'm not going to be a 9 out of 10 anymore. I'm going to come down a few notches, and explain to the orthodontist what you want to have done. Sometimes we have people coming in with unrealistic expectations. We used to laugh in the 90s and early 2000s that people used to come in and say, I want a Britney Spears smile. And that was the most asked for smile with people. They would come in with a magazine and a photo and say, I want to look like this. Obviously, we said you inherit things from your parents. There are limits, but of course, we always aim to have a positive change coming from the orthodontic treatment.
There's also this disparity when it comes to length of treatment for orthodontics. What determines one having braces or orthodontic treatment from 1 year to 2 to 3 years, and someone else getting it for just 3 to 5 months, for example? And also just let us know what goes into these different appointments when one gets braces.
Okay. Well, 3 months is a bit short. I think most patients would love to have braces for 3 months, and if they did, we would have people signing up all the time. Everyone would want to have their braces. I think the worst thing, you talk to a patient and you say, this is the treatment plan, this is what needs to be done. The patient is nodding away until we say the average time for treatment is 1.5 to 2 years of treatment. And at that point, you can see a little bit of a frown coming in. It is a big time commitment from the patient. There are some cases where a patient might have treatment for a very, very short time, but that's usually when we spoke about interceptive treatment. So when the child is young and we're just going in to do something very small, like move one tooth into a better position, that's where you might have a 3-month course of treatment. But the majority of cases, we're talking about 1.5 to 2 years. That's the average, and that's because there are stages that need to be worked through. So we're starting off with aligning the teeth, and then we start to level the bite and make sure that the bite itself is correct. And then the final stage of the aesthetics, how is it looking in terms of the smile aesthetics and things like that. We do know that, increasingly with social media and advertising, there are things called the 6-month smile. And a lot of patients will come in and say, I want this very, very quick, short course of treatment so that I get the 6-month smile. But as an orthodontist, we have a responsibility to not just treat the teeth that you can see. We need to treat the full problem. So we're looking at the bite itself, as well as the appearance of the teeth, as well as how straight they are. So usually, if we're going to do that full course of treatment, it's going to take 18 to 24 months. Some patients have complicated cases, the ones that are going to involve oral and maxillofacial surgery, or bringing an impacted active tooth into the mouth. And those ones are going to maybe take a little bit longer. Those are the ones we're looking at 3+ years. In some cases, we also have to go in a little bit early. The ideal age, as I said, is going to be during adolescence, but sometimes the treatment might start when the patient is only 8 or 9 years old, and then things start to evolve. Teeth start to fall out, the baby teeth are falling out, new teeth are coming in, so that can sometimes prolong treatment. These are all the biological factors or the things that we are, not really in control of, because it just depends on the growth of the patient. But there are some things that the patient themselves is responsible for.
Okay.
Often people are coming and they'll be complaining to the orthodontist to say my treatment is taking a long time. But the question is, are you following the advice that you've been given by your clinician? You need to take care of those braces. Every breakage of the bracket or the appliance is going to set you back. It's like snakes and ladders. You know, when you get to number 99 and you're almost at the end, it's the same in braces treatment. If you break a bracket or break something and you're almost at the end of treatment, that means that the orthodontist has to go back to the aligning wires to bring that tooth back into position, and that's going to lengthen your treatment. So following things like dietary advice, cleaning the teeth, looking after the appliance, that's also going to have a bearing on your duration of treatment.
Okay, all right. Thank you so much for that. So all depends on you when it comes to length of orthodontic treatment. So what has been spoken of more lately is clear aligners when it comes to bracing oneself and orthodontic treatment. So Dr. Nhembe, please do tell us a bit more about clear aligners, who gets them, and how are they different from, the conventional braces in orthodontics?
Sure, Tracy. So clear aligners are, as you say, gaining increasing popularity. And it's probably because with the conventional braces, they've always had these negative terms, associated with them. People calling you brace face and saying you've got railway tracks and all of that, metal mouth and all this. So we've got a little progression within orthodontics. We started off with the full metal braces, which are the most common, and in terms of efficiency, I still think they are extremely efficient. But we started getting a move with patients asking for slightly more aesthetic appliances. So from the full metal brackets, we started getting ceramic brackets, which are tooth-colored braces. And patients were a bit happy having something that's not as obvious. And then over the years, there's been this complete shift to clear aligners, as you say, because then patients want to go through orthodontic treatment without having people know that they're going through orthodontic treatment. So a clear aligner is made using computer technology. We all know about 3D scanning these days, and that's why we've had this big move to clear aligners, because the 3D scanning and 3D printing is not just in the commercial world and other aspects. It started coming into dentistry, mainly with the dentists and how they're making their crowns, but this is where it features in orthodontics, because we mentioned that the gold standard of tooth movement is when you can 3-dimensionally move a tooth. And we can now do that because instead of just taking a mold of the patient, we can now scan using an intraoral scanner. And once we have a scan of the patient, we can then start to plan the treatment in terms of individual movement of the teeth. And it means that these files can be shared with the big aligner companies or the laboratories, so that we can then plan as the orthodontist or the dentist how we want the teeth to move. Once we've planned that, they will then send us a few files which are called a clinical check. And that clinical check is essentially showing us how we can take a patient from stage A all the way to Z. And that's because we want to then see how can we move the teeth if they're out of line to then get the perfect bite. That is done using aligners. So a patient will then, once we've approved of the clinical check, we will receive a box like this, and commonly a patient will have 8 to 10 aligners per treatment, and then right at the end they'll get some retainers to hold the teeth in position. So this will be showing, for example, the beginning of treatment. We sometimes put little attachments using a tooth-colored material on the tooth, and then the patient is then given an aligner. So you go off with a set of aligners. Commonly, you will get the aligner for the beginning, and then you would wear that aligner for 2 to 4 weeks, depending on how the teeth move. Once that aligner feels, you can see once you start, it's quite tight on that model. The patient will then start with a very tight aligner. Once it starts coming out quite easily, up and down, they would then progress to the next one. So they would put the first aligner away and then go to the next aligner. and they would work through sequentially through those aligners. As the orthodontist, you're still seeing the patient for checkups, so they would still come in. Sometimes we need to file in between the teeth. Sometimes we need to just put another little rotation nodule on the tooth. And then as we go through treatment, they get to the end of treatment, and that's when they would then, if they're happy, they would be fitted with a retainer. The benefit of the aligner system is, as we go through treatment, we can keep scanning the patient. So if they're not happy, for example, with the way the teeth are looking, we can then go back to that, I'll call it a parent agency, so the aligner company, and we can just say, it's not quite going to plan, we can scan again and then plan that treatment through. So a lot of patients are happy with that because it just looks like your teeth, and yet you're going through treatment. The drawbacks of it, however, initially were there weren't many companies. It wasn't something that was commonplace, so it was really, really expensive when you compare that with the conventional braces. So it's not so much now a case of aligners versus conventional. It might be a patient's choice. So a lot of patients might say, I don't want something that's very obvious. In the past, the aligners weren't very efficient. So we would still say if it had complex movements that we needed, or if we were extracting teeth, we definitely wanted the conventional brackets. But now the technology has changed so much, and you can do practically everything with the aligners. And as I say, it might become a little bit more of a choice if it comes to cost, but once again, with the increasing 3D scanners being available, the prices have come down on those. They're more commonplace in practices. So you tend to find there are more aligner companies. And with that, then it then brings the price down because we're not relying on one, main brand of aligner. And it has become so accessible to patients. So it's something that we discuss and have offered to patients as well.
Oh wow, thank you so much for that in-depth knowledge on aligners. So Dr. Nhembe, you did tell us that you work hand in hand with different branches of dentistry. You work with the periodontic dentist, you work with the general dentist, and even with the maxillofacial surgeons. So we are interested to know a bit about the surgical parts. When do people need surgery before orthodontic treatment? When do the surgeons come in?
So some people need surgery before orthodontic treatment, and some actually during orthodontic, and then some at the end of orthodontic treatment. So I'll explain that a little bit more. We have minor oral surgery procedures, and then we've got the major oral and maxillofacial surgery procedures. Still, both are done by oral surgeons or our oral and maxillofacial surgeons. For some patients, they may have a big gap between the teeth, and that could be caused by a frenum, which is a muscle attachment, and it may just be a little bit lower or wider than it is normally. And that's something that we would refer to an oral surgeon, and we would say, please could you reposition the frenum or remove the frenum because it's interfering in keeping those teeth apart. So that is something that might be done at the beginning of treatment, but is commonly done once we've closed the space and we're ready to take the braces off. That's something that would be referred to a surgeon. We might also have teeth that are impacted. Commonly, the canine teeth would be impacted in the top jaw in the maxilla, and we would refer to a surgeon so that we create the space for that tooth using the braces, and then the surgeon would go in and attach a gold chain to that tooth, which we will then orthodontically guide into position and then put a bracket on the tooth to bring it into alignment. So that's something that we need the surgeons to assist us with. And then we have cases where the jaws themselves are in an incorrect position. So that would be the orthodontic surgery. So this is a whole different branch even within oral surgery itself, and the maxillofacial surgeons are responsible for this. And this is where we as orthodontists can get the teeth into a certain position, but sometimes it's even a greater problem than just the position of the teeth, but the jaws themselves that need to be moved. And this is where the surgeons would go in. We would start initially to align the teeth and get them into a good position, and then the surgeons would go in and perform the oral surgery or the oral and maxillofacial surgery itself. And this is usually done about 6 to 9 months into the orthodontic treatment. Once the jaws are in a better position, we then come back in with the orthodontic side using elastics to guide the teeth and the jaws to then set them in that new position. So this is where we have the interaction between the oral surgeons and the orthodontists.
Oh wow, lovely. Okay, so as we round up the video, Dr. Nhembe, our last question that we have for you today is about a retainer. it is commonly spoken of that after you've had braces done, after your treatment is done, you need to wear a retainer for life. As nice, lifelong. So could you tell us about this? Why should one wear a retainer lifelong? What's the benefit of it? And possibly the adverse effects of not wearing your retainer?
Yeah. Okay, so this follows anything else in life. If you break one of your bones, you're going to have a cast put on for a period of time, and that's to allow things to set. You want the bone to set in that new position. The same applies to if we're moving teeth. We are moving them from one position to another. What's going to stop them from wanting to go back to that original position? You know, the teeth are tethered to the bone using a ligament, and that ligament stretches as we derotate the tooth or move it, and there's always a little bit of a tendency for that tooth to want to try to go back to the original position, and that's why we say retention is for life. I had braces as a child, and I actually was given a retainer, and I wore it for, at that time we used to say, wear your retainer for 6 months. I wore it for probably 2 months because patients never do what they're told. And then my teeth moved, and I ended up having to have treatment again. And it's so easy to want to blame the orthodontist or to tell, you know, your parents, I wasn't told to wear my retainer that long. And that's why now we say retention is for life. Because there's a bit of a responsibility that comes in on the part of the patient. We want the patient, you're brushing your teeth every day, you're looking in the mirror every day, look at your teeth. If something is trying to move, then you know I need to wear my retainer. But of course we have a lot of teenagers that finish treatment and they'll say, I have so much homework, you have no idea what I have going on in my life, I can't remember to wear this retainer. And that's why we have 2 types of retainer. We have the common plastic removable retainer, and this is the one that you take in and out. Initially you have to wear this one full time. So we say full time for the first 6 months, and then night time, and then we just tend to moderate it. But what has been increasingly used are fixed retainers, and these are glued behind the front 6 teeth in the top and the bottom. And this then takes away that, I forgot to put my retainer back in after I was eating. And with the fixed retainers, we want them to stay in place up until the patient is 21 years old, if it's a boy or male patient, and with a female patient, maybe slightly earlier because their growth stops sooner. So we still say, even with the fixed retainer, you still have to come to appointments to have them maintained, and you still have to be just checking, are my teeth looking as perfect as they did the day that my braces were removed?
Great, wow. So we have been loaded on some in-depth knowledge on this branch of dentistry, bracing oneself, which is just orthodontics in a nutshell. Dr. Nhembe, thank you so much for being a part of this and for just giving us your depth of knowledge, your background and experience on this branch of dentistry called ortho. So as we round off, is there anything else you'd like to add, maybe that we didn't talk about, or anything that you feel is important for the dental students who are watching this, or the general practitioners, the dentists, and even the practicing orthodontists as well?
I would probably just say, do your research. If you're a patient who's about to embark on this journey, it's a fun journey. Orthodontics, we say, it's the lively, vibrant part of dentistry. We have so many colors that people can choose from. It doesn't have to be a miserable 1.5 years to 2 years. But don't go into it just expecting it to be a simple cosmetic procedure. Get to know your orthodontist, get to know the team. You're going to be with us for 1.5 years to 2 years, so make sure you like the person that you pick to do the treatment. And I would just say, know what's coming. Increasingly the younger patients will come in and they already know about braces. They've done their research. It's on YouTube, TikTok, all the social media platforms. And I would just say, come in with a positive attitude and you'll have a positive outcome.
Wow, thank you so much, Dr. Nhembe. It's been so exciting to have Dr. Nhembe on this platform, and it is such an honor to have such an established orthodontist right here in Zimbabwe giving us some in-depth knowledge on the field. So thank you so much for watching this video, and hopefully you're ready to brace yourself.
I put my trust in you, cause you give me comfort. You know the man that you should like.